Then he did special training in epidemiology and infectious disease at the Centers of Disease Control before joining the faculty at the University of Utah in infectious disease in 1978. In 1988, medical ethics was becoming a discipline very new in medicine, so he went to the University of Chicago's Center for Clinical Medical Ethics and then returned to Utah and really established the new division of medical ethics there with the law school, medical school, and the College of Humanities. Since that time, he served on the American Medical Association's Council of Ethical and Judicial Affairs and the American College of Physicians Ethics and Human Rights Committee. He has chaired the School of Medicine's Institutional Review Board, and since 2005, Dr. Jacobson has directed the Robert Wood Johnson Foundation Project, which is a partnership to improve the end-of-life care in Utah. Recently, he received the American Medical Award for Leadership in Medical Ethics and Professionalism. With that, Dr. Jacobson.
I understand that my microphone will work right here, so I think I'd prefer to do that. It's a huge honor to be at the Ogden Surgical Society meetings. I've actually had the honor of helping recruit some of the speakers who've come up here to talk to this group before, but not had the opportunity myself. And it's a wonderful and fortuitous coincidence to be introduced by a former student from the University of Utah. So I'm delighted to be here. This is a challenging topic that we're going to talk about today. And I started with the assumption that you might have more than one group to choose from. I was going to ask you why you chose this group, but my understanding was your choice was either to come or not to come, rather than to go to a different group. But I think there's another question that might be just as useful, and that is, since you came, what were you hoping to learn from a discussion which was about disclosing and managing medical error? So I'm going to ask you to think about that for a minute. What did you come hoping to learn about that topic? But you can help me by giving me a sense of who I'm talking to. So it's the Ogden Surgical Society, but out of the 3 people I've met so far, none were surgeons. So if you're a surgeon, could you raise your hand? Okay, well that's great. I'm assuming that the rest of you are in medicine or health-related fields, but from a wide variety of things besides surgery. And so my talk, I would say, in our discussion is fairly generally applicable, but because of the meeting and because I've actually not talked with surgeons directly before about this issue, I'm going to say some things today that are directly applicable to surgery. But how broad will it be? Well, it's broader than medicine. Talking about mistakes obviously has application in everything we do. And talking about apology, equally so. So my hope is actually that what we're going to do is partly skill building today. We're not going to talk so much about whether or not to disclose or apologize. That's a decision that you're going to have to make each time the situation arises. But one of the reasons that we sometimes choose not to disclose or apologize is because we really don't know how. So one of my hopes today is that you'll leave with a little bit more material to think about and strategies to consider when the opportunity, if we can call it that, or the situation arises where disclosure and apology are appropriate. Fair enough? I have one other goal besides skill building. The other goal is to try and see what this looks like from the other side. These are complex issues for physicians. The idea of making a mistake to begin with is a very emotionally loaded concept for us. It's something that we don't want to do. Some people even imagine that you could go through a medical career and not make a serious mistake. So if you believe that's possible and you make one, right, that's a devastating experience. So making a mistake is very, very deeply emotionally charged for physicians, let alone disclosing. So we're talking about something that has a lot of weight to it. And that's pretty much the same thing with apology. To make matters worse, there's a lot of ambiguity, and we'll talk about that. The word that we use in English to express regret is I'm sorry. It doesn't mean that I'm responsible for what happened to you. It means that I regret what's happened to you. It's what we say when we learn that a friend has lost a parent. We say, I'm sorry. It doesn't mean that we had something to do with the death of that parent, but the ambiguity of that is an inhibiting factor on our ability to express regret, because I'm sorry can also mean I'm responsible. And so we worry a lot about bad things that happen to people when we are regretful. We worry that saying I'm sorry may be confused with I'm responsible. And that may actually create an additional problem. It will create a problem where there was none. In the first case, we're just expressing our sincere compassion, but if it's misunderstood, we may be perceived as causing a very unfortunate outcome or maybe even a death. And the consequences of that for physicians, again, are dire, right? When I say to my neighbor, I'm sorry about the loss of your father, my neighbor appreciates my sense of regret and concern. When I say to a patient, I'm sorry about the death of your husband in the OR, right, that can be misunderstood as an expression of responsibility and create a whole cascade of things that I think worry us, concern us, and of course inhibit us. So one of the things that I hope you'll remember from today, or there are ways in English of expressing the difference between regret and responsibility. And the difference is the word apology. The word apology is not ambiguous. So if I say, I apologize for the death of your husband, I'm in a very different zone, right? That's very clear that I am connected to this. Both parts of that, I and apologize. I'm taking some responsibility for that, and we can go on and talk through that. I can also say I'm sorry, right? I apologize for the death of your husband, and I'm sorry. That actually adds regret to the acknowledgement of responsibility. Can you see the difference there? Imagine someone talking to you. And the other way, if you want to escape the confusion that comes with this natural desire to say I'm sorry when there's a bad outcome, you can use the language called I wish. So, for example, if an adverse event occurs in the operating room, you can see I'm focusing on surgeons. But for my internist colleagues, it's exactly the same thing. We use a lot of drugs, for example, that are designed to help people. But predictably, many times those drugs will produce adverse effects, right? We're not happy about that. But if we say, I'm sorry, that can be confusing. What you can say is, I wish, and follow that up with appropriate details, right? I wish that this event, which occurs in only 5% of the people who take this drug, did not occur in you. That helpful? So we really talked about three phrases. And I think those three things can actually help a lot. At a minimum, they'll help you avoid ambiguity. And I'm hoping they will give you a little bit more confidence to say what you're feeling without the reticence that it will be confused. So 3 strategies. I'm sorry is something that you can say, but remember when you say it that it can be confused. So you probably want to say more if you say I'm sorry. But if you want to talk about something that you had responsibility for, you actually need to use the word apology. Because saying you're sorry when you're responsible doesn't convey that you feel responsibility. It only conveys that you feel concern. Okay? That's great. I think if you can think of those 3 things, we're in very, very good shape. Now, you've had some chance to think about what it is you were hoping to learn. So tell me a little bit about it, but also tell me what kind of physician you are. That will help me. So if you don't tell me, I'll point to you. What were you hoping to learn? Yes, I'm patient. Go ahead. Okay. So absolutely. So the question, if you didn't hear it from the back, is what is an error? So someone at least came hoping to leave with a little clarity about that. And you've actually already heard me use some words that kind of come into this word salad, right? Complications, adverse outcomes, mistakes, and errors. For my surgeons, have you used surgical misadventure? It's one of my favorites. It doesn't, as far as I know, it doesn't exist anywhere outside of medicine. Never heard of a CPA saying, I'm sorry, that was a mathematical misadventure. Anybody else that came with either that hope of learning or a different goal, something that you were hoping to learn when you came? Sure. Okay. So this question was, how can you determine when, and I'll use the generic term, when something goes bad, how do you know whether that was due to chance, whether it was due to error? By the way, it could even be deliberate, right? I mean, bad things that happen, for example, when people die deliberately, we have a name for that, homicide, right? And it's not unprecedented in medicine. There have been deaths on intensive care units where people have caused the deaths. So bad outcome could be a mistake, could be chance, could be a systems error, right? The individual physician might have actually had no role at all in this bad outcome. It's a very complicated area. We'll take a little time on that, distinguishing bad outcomes from mistakes or error. I'm pretty sure I saw another hand. Yes. So I'm going to paraphrase that. So that's actually a wonderful example from surgery. So what this individual, are you a surgeon? Okay. So what this surgeon said was, and you be thinking about bad outcome, mistake, error yourself, or system problem. I was told the sponge count was correct. It obviously was not. There is a retained sponge. And his concern, that's already even a question of whether that's appropriate in conversation. Right? What we know is there's a retained sponge. So keep that in mind. Then the next one is his concern was about fault. Right? What do I say about fault? And another question is, how do I determine who's at fault? Okay? That's three very different kinds of questions. Yeah? Sure. Sure. This question was, in a way, it's what's a nice way to say that? It's the whole subject now is not so much my own mistake, but the mistakes of others. And within medicine, of course, there are many elements to that. I may be the one that discovers the mistake of another who didn't even know that a mistake was made. So there's the issue of discovery, and who do I tell? Do I tell the mistake maker or the person who might have been injured by the mistake? And by the way, I can discover mistakes that cause no injury. Correct? It's another fascinating thing about medicine, is that a skilled reviewer of the medical record, right, or even a radiologist looking at a film, may discover evidence of a mistake which is not causing present harm and which may cause no harm, but it's a mistake nevertheless. So the question here was, to whom do we disclose that information? It's almost a second-order question. What I'm going to tell you is, we won't get to all the questions. There is literature, actually, about that as well, and my focus today is very much going to be on the doctor who knows about a mistake and the patient and family who are affected. But you're really right to bring that up. Yeah. Just repeat that one more time for me. Seriously, I want to be sure I understand it. The appropriate timing versus insurability. So it was a question that used the word timing, but the reason I asked you again is because there's more in your question than timing. So the way it was phrased is timing of disclosure to a patient versus your insurability. Well, it's more than timing, it's also choice. So you could say the question includes not only when, but whether to disclose and apologize. Because whenever you disclose and apologize, there has to be some element of risk that this could come back. We talked about the fact that our colleagues may not know the mistakes that are made. It is the case that the vast majority of patients in whom mistakes have been made do not know that a mistake has been made. So disclosure to the patient may actually be the first time that a patient understands that a mistake has been made. I'm going to use our surgeon's example. That patient may absolutely not know that a sponge was retained. Fair? I mean, they would have no way of knowing that at the present moment. They might discover it later, or they might not. That's a chance element. It might hurt later, or it might not. We don't know any of those things, but what we do know is the patient doesn't know. So look at the choice that your question gives our surgical colleague, knowing that his patient doesn't know, right? And even knowing that the harm is uncertain, it's a very loaded question, whether you want to share that information with the patient. So that brings up an excellent point. Maybe one other goal of something to learn, and we'll start to go to work on meeting your needs. Yeah. Okay. This was when you learn of, and I think you use the word event. So we'll say event or mistake or complication or unexpected event, adverse event, all of those. The question is, in what sequence do you talk to people and to whom do you speak? Do you speak first to your risk manager? In my surgeon's example, would you first go to the OR and have a conversation about who counted the sponges? Would you call your lawyer? Lots of questions about where to go first, and I think we'll probably get to those. So I'm going to hold right there, but you have the chance to interrupt with other questions. So let's start to cash out some of those. Let's start with the first part, which is, how do I know if it's an error? Right? And let's again start that in medicine, people are very complicated biological beings. Oftentimes we're surprised by things, things happen unexpectedly, and a lot of bad things happen to people that have nothing to do with errors. It's absolutely possible in medicine to do everything that is known about treatment and do it correctly, still have a terrible outcome, including death. So one of the problems is, how do we distinguish between bad outcomes and errors? Right? Well, what gives you a clue that an error might have been made? A gut. Someone said an intuitive feeling or a gut feeling. But let me just say that as human beings, our biggest clue to errors is something bad or unexpected happening. That's actually the trigger that alerts us to that. And that's a very fair question, right? Something unexpected or bad. Obviously, the doctor didn't intend either one of those. When they talked to you about the surgery or the treatment, they didn't mention this event, so it's unexpected. And if it's a bad event, more pain, loss of function, new symptoms, rash, any of those things, right, there could be an error. That part is correct. There could be an error. In medicine, but we know it doesn't mean there has to be an error. Correct? So we already know there's a problem. That using a bad outcome or an unexpected outcome as an index of errors is an imperfect tool. You with me? So it suffers from specificity. Many bad outcomes are not, in fact, errors. Now let's go the other way. Is it possible that serious errors can occur with no bad outcome? Okay. Yeah. So, well, no, that's a pretty bad outcome. Wrong side surgery was the example. What I would say is that's an error with a terrible outcome, right? You could come very close to that in the OR, couldn't you? That is, since we've had wrong side surgery cases, people are doing these kinds of checking, right? Let's check that the x-ray is turned the right way. Let's look at the leg that's marked. It's possible, I think, still that the wrong limb could be prepped in the OR, and you literally are ready to operate when someone doing one more check says, wait a minute, I think it's right, not left, and you stop. That's called a near miss. Okay, we'll talk a little bit about near misses. Near misses are actually terrific opportunities to learn about mistakes without making them, right? So think of the drama of that. How would you feel if you were this close to operating on the wrong digit or the wrong limb, and somebody who did the fourth check, right, said, wait a minute, this doesn't add up. So we learn from near misses, but in fact there are mistakes. I'm an internist, so very bad, and I do infectious disease, so I treat infections with antibiotics. So a bad mistake for me is to know that someone has an anaphylactic reaction to penicillin and beta-lactam drugs, and what do I prescribe? Right? I prescribe a drug in that category. I'm having a senior moment, And, it's ampicillin, not penicillin, or piperacillin, and somehow I didn't recall that. Do all the patients that I make that error in have an anaphylactic reaction? No. Is it a mistake? Yeah. So we've now learned kind of the two extremes, and we know that this is hard. Given that, how would you distinguish a mistake from an adverse outcome? The patient is dead. Does it get more serious than that? You have a patient who died unexpectedly. That's terrible. Was it a mistake? Or a complication? How would you decide? This is actually something that we work through almost every day, right? So I think there's some expertise here. How would you decide, faced with a bad outcome, whether it was the result of a mistake or not? So you would start looking backwards. You first have to do some investigation. It's not enough to know that they died. You'd want to know why they died, which could take things like an autopsy, review of records, etc. So maybe the first point is not to react reflexively. That is, while a death could be a mistake, it could also be a complication of surgery. By the way, it could be a coincidental effect. I'm looking at an ENT surgeon who could have done a procedure on someone's ear or nose, and later that night they expired. Right? They could have had a stroke. They could have had a fatal arrhythmia. They could have had an MI, all unrelated to the procedure. So I think the first thing about errors and mistakes and adverse reactions are to understand what happened. So that may actually take a little while, and it may take a lot of thought. And we need to be careful not to leap to conclusions. Let's think about the patient's perspective for a minute. If that death was unexpected, would the patient imagine that a mistake might have been made? Absolutely. Because they're human beings too. And bad results often indicate mistakes, but not always. And in my example, that might have been somebody who was a jogger and a marathoner, and the last thing on anybody's mind would be a heart attack. But we know that happens. Bad luck for you, it could happen the night after your surgery. Right? Okay. A lot of background there. So distinguishing mistakes from adverse events. First of all, think about the kind of surgery that you're doing. There are a list of things that are anticipated complications of that surgery. Right? In the same way that when I prescribe a drug, there are a list of things that are known to happen with that drug. If that's what the bad result is, and I gave the drug for the proper reasons and in the proper dose, then I probably have an adverse event, but not an error. Sound okay? All of this takes thought. It's also quite complicated. There can be a combination of problems on the host side, for example, that I may not know about, and an error that I've made, so that my error is contributing something to that adverse event, but is maybe not responsible for it. In the same way that a host factor made my error worse in that patient than it might have been in another patient. So complicated but not impossible. The people who best decide that are your peers. So if you're an infectious disease person like me and you can't decide if this problem this patient is experiencing now is due to my mistake or a predictable complication of the treatment I used, my peers who know about the drugs I use and the diseases I treat are probably best equipped to decide, just as your surgical peers are probably best equipped to decide whether your choices when you made them were correct choices. Let me emphasize, that's actually the moment in time to look at, not the outcome. We all know there was a bad outcome. That's really not the question. The question is, did you make the right choices and execute them correctly before the bad outcome occurred? Right? So the focus in making the judgments about mistakes and errors is to look backwards in time at what was done before the outcome was known. So in my case, the story for you about penicillin, remember, people can have anaphylactic reactions to a drug the first time it's used. So I have a patient with anaphylaxis, and I'm trying to decide complication, bad event, adverse event, or an error. So I look back, and I look in the record. If the record makes no mention of a previous allergy. And if I actually document that I asked about allergy and there was none, then it doesn't look like I made a mistake. Next level. Did the drug I used, was that a reasonable choice for the condition I was treating? Can you appreciate that mistake? If I made a poor choice of a beta-lactam, even though there was no allergy, and another drug was a far better drug, or the drug I chose was not indicated at all, I've still made a mistake. Right? It was the wrong choice of the drug, and it led to anaphylaxis, which would have been avoided if I'd made the right, not the wrong choice. So, bad event, good flag. Look backwards, see if we perform correctly, correct judgment, and correct execution. Okay? Now, what about no bad outcome? How would we ever find those mistakes? Is it possible? Sorry? So chart reviews can actually reveal mistakes. Remember my story about penicillin? So I can actually give, statistically, penicillin to people with a history of allergy, and more often than not, they won't get sick. But if I look at all my records and I compare history of allergy with drugs prescribed, I will actually find the cases where I gave a drug that I shouldn't have given. So we can find errors that don't cause harm. Right?
There's so many people think that a penicillin allergy don't. You may be helping them by letting them know it was just a thing that the mother told them when they were 1 month old.
So here's a nice example of what we do about mistakes in medicine is we rationalize. I'm going to use your language. So it's actually, and it's actually a true point that was made. How helpful was I by giving the drug to the patient who thought they had an allergy? And now we're going to talk about disclosure. And I step by and I say, I want to tell you about something I did that was an error and it didn't do you any harm. Better yet, it did you good. This is the most finessed maneuver for mistakes disclosure. And I'll show you a cartoon that we do this all the time. You should be so glad about the mistake that I made. So a couple of points. I mean, it's conceivable that some of our mistakes are actually very instructive to patients. They also can be instructive to us. In that particular case, I'm fighting probabilities. The fact is, the next time I give that patient the same drug, they may teach me that they actually did have an allergy. So it's a zone of uncertainty. All right. What I want to do is talk a little bit about feelings here and then show you what I said was one of my goals, which is how this looks from the standpoint of patients, and then we'll end with some skill building. And what I want to tell you is that Beth has been wonderful. She's going to pass out a handout you can share. And if you don't think you'll ever make a mistake, you can leave it with your partner. Okay? But if you do, then you should take it with you and put it in a folder called mistakes. And then when you make one, you should go back and read it. You will never give it more attention than you will at that time, and you'll look at it more carefully than you will today. But that's what I want to assure you about. We won't cover all the slides together, but it's there for you to take home. Okay. Now, would you help me with it? Oh, no, wait 1 second. Let's just talk about what it feels like to be a doc who's made a pretty serious mistake. Can you talk to me a little bit about that? If you can talk from your experience, that would be the best. But if not, talk from your imagination. How would it feel if you made a serious mistake? Yes? Talk real loud, too. First of all, I think we're all feeling very briefly the story, somebody who had laboratory signals of respiratory failure but who didn't look clinically quite that acute. So a physician who didn't want to do more harm than good by intubating didn't intubate. A short time passed and the patient expired. Okay, that's all we've heard. How were you feeling then and even later? you're a guy, right? That's how we talk about feelings. We made a mistake, and it was wrong. But the question was, how did you feel? So what you already said was you didn't feel guilty. That's helpful to share that. What did, if anything, did you feel? Well, it's fair. So let me just take advantage of that, because other people were feeling when you told your story. So I first thank you for the story. So let's talk about that right in that moment. So that was you. You heard the details. How would you feel? And what would be going through your mind? Because it's not over. The patient expired. So somewhere there's family. I mean, there's a whole world out there, and there's probably another patient you need to see. How about the rest of you in that situation? How do you imagine you might feel? Say again? Devastated. First of all, congratulations. You had a great English teacher. I think devastated it's a wonderful adjective. You know, it gets this sense of tremendous trauma and destruction, and you know, what's coming down? What, in fact, about you has been devastated? Can you think of that? Yeah. So I'm going to put some words in, and you correct me if they don't feel right. So I asked the question, what was devastated? And the answer was, it's my job to save lives. And he used very good words. It's possible this patient died despite my effort, or maybe because of my choices. We're not sure yet, but he died. But my job is to save, not to have patients die. So in a way, my identity is a little shattered right there. I mean, you know, other people use words like, you're a healer. Well, your patient just died, right? You were not a healer there. Some people worry that their reputation will be devastated. What about my colleagues when they learn, and if they make a judgment? We're back to bad outcomes and errors. If my colleagues think that was an error, how will they feel about me? I'm an academician. I'm a professor of pulmonary medicine, and I just had somebody die of what? Respiratory failure? How devastating. There were some other hands. How would other people feel in that situation? So if you're wanting to feel a burden, you could begin to think not only about me and how I feel and how people will feel about me, but then there's this family of this gentleman with COPD, and his wife has heart failure. How confident will she be going to her physician after what she's witnessed over here? You know, have I messed up not just for myself, but I've kind of sullied the whole field? By the way, some of this is exaggerated and catastrophic. On the other hand, it's how human beings feel at moments like that. Any other feelings? So we have, I'm going to keep using devastation because I think it's right, but there are some different feelings. Yeah. So I'm questioning myself, and doubting might be another term. I might even lose respect for myself. That's all very internal. But it can be devastating in my future. In other words, if I become very tentative in the future. This is a wonderful example, because in some ways, you know, we think about action or inaction. Ethicists will tell you what's important are decisions. So whether we act or don't act, what's important is our decision. But in this case, I mean, young people doing an experience like this have often chosen different specialties. So it can be that powerful that it redirects them. If they die because of something you did, some physicians in a specialty won't do that anymore, right? If I'm an invasive cardiologist and early in my career I have something that I thought was right but my colleagues tell me was wrong and a patient died as a result of that, I might decide to become a different kind of cardiologist. Is there another hand over there? Yes. Okay. So these are two, and notice the power of these words, devastation, shame, and remorse. And they're two different things. So if you don't mind, I just want to speak a little bit about it. Shame fits very much with this comment about not living up to your own standard. Right? Shame is a very strong word. I didn't do what I knew I should do or what I was supposed to do. or I'm ashamed that I didn't know what I was supposed to do. It's very internal. If I'm feeling these feelings because of what other people think, that may be shame. It's also embarrassment. Embarrassment requires other people looking at me to give me those feelings. And remorse is a feeling of, in a way, being sorry for the fact that it happened. It's a huge feeling of regret, right? That's the one about, why did I do that? And then all this kind of rationalization. If I'd come to work a little later that day, my colleague would have seen the patient, right? Either he would have made a better decision, or if he did it, it was his problem.
What about the hopeful rationalization that maybe the guy just got dead of a heart attack or a stroke and it really was, arrhythmia, and it wasn't,
Okay.
there's no sign of it.
Let's go back to what you just said and remember what we learned in the first few minutes. Can I actually get you to hold? I'll give you the floor, but let me just say that what we also have is something that's a dynamic that we're all familiar with, right? How do we deal with the ambiguity of whether something is a mistake or not a mistake? Which is the one we don't want it to be? Right, we don't want it to be a mistake. The only reason I asked was that I just wanted the group, as a group, to remember what we said and the language over here. This comment was something like, this person died despite what I did. It could be that. It could have been exactly the right treatment and he died anyway, or because of what I did. That's actually looking at your question, right? Because the unexpected event would be despite my best care. So what we learned in the beginning was that we shouldn't rush to judgment. That when there is a bad outcome, while it's a signal, it's actually for us a signal to investigate. Is that fair? So that the question also in the back before about when to do disclosure, not before you know that it's a mistake. If you have a bad outcome and you choose to disclose it as a mistake, and it's not a mistake, you haven't done anyone any good. That also applies to apologizing. It's why we learned the language of regret versus apology. If there is a wife in the waiting room, there is no such thing as going too soon to say that a death occurred and that you wish it hadn't, right? There's no reason to delay that. There's every reason to delay saying, I apologize for the death of your husband, until you know you have something to apologize for. Now, with that said, you have more to add. So it's another really good point, but can you see how complex that is? Because that's something we actually don't know in real time. We just don't know. It's very plausible, right, that it couldn't be done. There are many things we don't know about your patient. We don't even know for sure, I don't know, that the lab results were right. What you presented us with was a dichotomy between clinical appearance and laboratory results. We've all seen that before, correct? And we also know that the right thing to do many times is to be skeptical about the laboratory, correct, and treat the patient. That's a lovely point to make. The judgment about right or wrong action, error or not error, can only be made before the event occurs. You have to go backwards. You have to review all of the elements that were in play. And you have to actually test your hypotheses. And just, we're going to move on. But your case is even compatible with wrong lab results and death for another reason, right? I mean, it could be. We don't know that. Well, again, but that may also be because it's somewhat unresolved still, even in your own mind, of why. The only point of all this is to point out that we can make our mistakes ourselves. You're in an ethics talk, but I'm not telling you to apologize and disclose every adverse outcome. Clear? I mean, that's not the point. The point is actually to query, to understand as best you can, and in your dialogue with patients, you can actually communicate that. You can actually say, we've been trying for the last 30 minutes. We tried to resuscitate your husband. We're trying to understand exactly what happened here. We don't know yet. I wish that this death has not occurred, but we're determined to find out why it occurred. We never want to see this happen again, and we will let you know when we know what happened. Another thing you can say is when and if we know. Let me also say we don't always get these figured out. That's actually enough about definitions and when to disclose. I'm going to underline that. You don't disclose an error till you know it's an error. Okay, same thing about apologies. So we have that done. Oh, one of the other questions was who to talk to. Who do you go to? You had that question. Depends on what you're thinking at the time. Some hospitals would like you to talk to them about a dire, unexpected event, regardless of the reason. An unexpected death, for example, generates so much emotion and concern that they may want to be out in front of that, showing their concern and helping with the investigation. So something as serious as an unexpected death, many times people want to know, the family needs to know immediately that there was a death, right? We understand that. But these other people need to know pretty soon if it's that serious. If you think that it was an error, it's probably appropriate to let your risk management people know about that pretty soon. It's not clear they need to know about it before you talk to the patient, but soon would be the maxim. The other thing is to think about somebody who you respect, who has good ability to talk to people about such difficult subjects as harmful medical errors. It could be a colleague. It could be your partner. It could be an administrator. It could be a nurse. So the idea of telling someone else does a couple of things. One is, it's your first experience talking about it for what it is. By the way, you should have lots of conversations to determine whether it is an error or not. And for that, you need your peers. They're the ones that the hospital risk manager doesn't know whether what happened in surgery was an error or a bad outcome. Your peers can help. Once you've had that, talking to someone else about the mistake is your first experience with disclosure. So that's good. That's practice. The other one is, if they will go with you when you do the disclosure, it's also support. This is a very hard thing for many of us to do, so having a second person with us is very helpful. And in fact, if you haven't disclosed to someone, you would do well to practice. You could actually grab a nurse on the floor and say, I have this huge task ahead of me. Can I tell you what I'm going to say? And you tell me, for example, if it sounds sincere. Does it sound informative? Or, does it make you angry? We want to remember that. Disclosure of mistakes can make people angry. Even apologies can make people angry, especially if they're not done correctly. So you want to practice. Okay, those are the questions. Let me show you a video. I told you it was important to see this from the patient side. It's going to take a little over 8 minutes, and you will appreciate how families struggle as we have, and they may never decide whether bad outcomes are simply complications or mistakes, but you will hear things about how they react to people who discuss these bad outcomes and how they discuss them. I think you'll find it valuable. Can we do the DVD? All right, we can do that. Let's talk a little bit more about feelings to see if we get them all out. We started with, I would say, almost a feeling of shock and surprise. When something unexpected happens, one of the first reactions is what happened. Right? And then we heard about shame and remorse, and no one said fear. That actually surprised me. Why would I say that? Why would you imagine physicians would feel fear? So, yeah. And I would say it's actually complex. We often rush first to a fear of litigation, which is interesting, isn't it? Why exactly do we have insurance? Yeah. Well, it's interesting. It also is to protect us. So in some ways, one reason that we're afraid of litigation, one reason, is that if we don't have insurance, it will cost us a lot of money. But most of us actually don't have that issue directly. It's actually a good thing to remember. One reaction might be, as a homeowner, when someone slips, you have two reactions. One is you feel badly, but you're generally not afraid. You pick them up, you call 911, and you're kind of glad that you have homeowners insurance. Does that sound fair? I've never felt afraid when somebody maybe had an accident in my house. All I want to do is help. Isn't that an interesting difference between our reaction to a patient who's injured versus someone who's injured in our home? So fear, but the fear is not actually so much about losing the dollars as it is, we're back to, what about my reputation? Right? How will it be if people know that I'm sued and they actually call it malpractice? It's agreed that it was an error. It's a lot about how I feel about myself and my reputation, my hospital privileges in the future, right? I worry about a lot of consequences. What else might we be afraid of? So we have a vision of the world, again, that's called catastrophizing, right? What we never worry about or think about is what will happen to us if we suppress, hide, or conceal this or deny it and it's later proved, right? It's actually a whole lot worse for our reputation and privileges, etc. But what we first worry about is what if we disclose it? Other things that we might be afraid of? How about the reaction of the spouse? Right? I mean, can anybody imagine going to a spouse to disclose a mistake, I'll do it personally, that I've made that's responsible for the death of your husband? I have to tell you, I'm sure I would be afraid of anything that might happen. Anger or tears or shrieking, right? It's a very scary thing to contemplate how that person is going to feel when I disclose new information. More than information, responsibility. How are they going to feel about me? This is a person who was fond of me. She was the referral. She heard about me and got her husband to come and see me despite his preference to go somewhere else. And I'm going to tell her what happened. A lot of fear. The reason I do that, are we ready with the DVD? What does that mean? 1 minute? The reason that I tell you that is it may surprise you that some of these same feelings actually are shared by patients on the other side of that mistake. Oh, I don't know if we talked about anger, but we should. Would anybody be angry about a mistake that they made? Yeah. What would it be like? Self-directed. It's like, it's one of those, if I had just, what's the matter with me? I've done this 60 times. What was I thinking when I wrote piperacillin for this patient? Right? You're very mad at yourself. The other one is to get angry at other people who often play a role in the mistakes that happen. What is the matter with the nursing care? Right? How many times, has that nurse caught a mistake before it happened? What was wrong this time? Right? What's wrong with our automated pharmacy system that's supposed to stop mistakes like that? So a lot of anger. So we have anger, we have fear, we have, kind of what will happen to me, right? And what does this mean? Those are all feelings that patients share. Well, let's go.
I still can play a little. I needed surgery as a result of an examination of my colon, which indicated some kind of a precancerous growth.
The surgeon comes out of the surgery and says to my mother that the procedure went well and the tumor was removed. The response of my mother was to be in such relief. Who doesn't want to hear that news? Was to run up to him, to the surgeon, and actually give him a hug.
I threw my arms around this man and hugged him for his wonderful job. Ooh, boy, would I like to take that away.
There was a problem that had to do with the first operation that created an infection, and therefore they had to put in tubes to drain it.
And they found that, in fact, there was another hole, and that it was draining into his abdomen. It took them 2.5 weeks to find out what was wrong with him. And by that time, I think an awful lot of his health had gone.
I was sent home for one day by the surgeon who did not take into account that I had a pneumonia.
The visiting nurse came and checked him over, and that was a shock, because what she found was a completely congested lungs and chest and all kinds of other problems that were occurring at the time. And so she called up the hospital, and they told him to come immediately into the emergency area.
They had no business getting me up on my feet if they didn't know how to handle me. The result on one occasion is that I didn't stay on my feet. I fell down.
The nurses dropped him on the floor, on his knees, and I could see that he had real injury on his knees and his legs.
The complications that occurred were of such enormity that it really took the wind from all of our lungs. It was almost as if a tornado came in and out, and by the time that the tornado left, there was a whole wake of questions and conflicts and emotional traumas and dramas.
I recall this woman chief resident as being one of the most delightful creatures I've ever met. And it's amazing how the aura of a room can change when this spirited, wonderful person enters, and you just feel wonderful. It's amazing how a doctor can alter your emotions. I think the head surgeon is lost. He approached me, I don't want to say this badly, but as if I were a piece of meat that he just sewn up, and if I would ask him, as I say, if I'd ask him a direct question, I would get we might say, an indirect answer. For example, the colostomy, I asked him, would I have to live with it, or could I have another operation? And his answer would be, that's up to me. Well, I mean, I don't know enough to make such a decision, and I would expect a surgeon to explain carefully the ramifications of one thing or another. And in terms of compassion or understanding another person's sensitivity, he did not make any effort to do that with me.
No one ever said they were sorry. That, that's what happens in medicine. They didn't say that. They just never attended to that. No one ever apologized for the condition that he was in, not at all.
If anybody would have acknowledged some accountability, an apology, to actually reach out and connect with us on human terms, in human language, not legalese, not the legality of a letter, primarily a sense that they were sorry and that there is a willingness for them to be vulnerable enough to acknowledge that there might be an imperfection in the system, and to acknowledge by accountability that the system can change.
You have no idea how far a sorry will go. As to what I'm going to do about it, I don't think there's anything I can do. There is no recourse. I'm not aware that I, in the role of a patient, have any power at all.
My father went into the hospital to remove the colostomy, and it didn't work out. We brought him home, and he died within 4 days. My mother wrote a letter to the hospital, and in that letter she discussed her concerns regarding my father's care. All she got back was a phone call asking if she planned to pursue a lawsuit. My mother became furious when she received copies of bills indicating that our insurance companies have paid the hospital hundreds and hundreds of thousands of dollars for the care we feel led to our father's death.
I wouldn't mind suing the hospital.
The objective of a lawsuit is never, for me, about a monetary gain. It is for the education of the system. It is to put the system under a microscope such that the system itself can benefit. Time heals, but it doesn't heal when there's so many questions that have not been answered, and that's a very difficult thing for us still to be dealing with.
So time is short. I'll just close with a few things, and if some of you want to stay and talk a little bit more about this very powerful look at the other side, we can do that. But I hope you saw a few things. Anger comes on both sides. This idea of what happened, this feeling of what really happened here, can be as mystifying to patients as it is to physicians. It's actually one of the reasons why disclosure is important. You also saw the blurring between mistakes and complications and the suspicion. They don't really know. So a careful discussion about actually what the doctors investigated and knew what happened would have been very helpful to them. It also shows respect. That language of being treated like meat, right, is very different if the surgeon had actually talked to them and used our language of, I wish this hadn't happened. That would have made all the difference in the world. Also, explanations. Even things like what we do with colostomies, they were at a loss. They were really adrift. So part of disclosure is just about information, and you do want to talk to your patients about bad outcomes and errors, because remember, they confuse them. So a careful conversation will help them distinguish. And if it is an error, you do want to discuss that as an error. You have this on a CD as well. You will see data developing now that things don't appear to be worse with disclosure. That is, it does turn out that if people are not told of a mistake that was made and then they discover it later, they're actually much more likely to litigate and they're more angry. So you can actually buffer that a little bit. The VA in Lexington is calling people back, where after chart review they find out there are mistakes that the patients don't even know about. And what they've found is that A, the patients appreciate it, B, they often settle. When there are damages that can be addressed by dollars, there's our settlements. When they compare themselves to other VAs, they have many, many more settlements. The others have fewer cases, but the judgments in their cases are equal to or greater than the settlements at the Lexington VA. So even in dollar terms, it doesn't turn out to be much worse at the end of the day. Apologies are incredibly important, and I want to end with that. If you have, and I will say the misfortune, but it will happen to all of us, to discover an error that you've made that's responsible for a terrible outcome, there's huge shame and remorse and guilt. And really, no one else can address that or take that away. You can talk with your colleagues about it, and they will commiserate, but they actually can't forgive you. They don't have that ability. Another term that's used is absolve. And what you find when you do disclose and apologize, it doesn't happen all the time, but it can happen that what patients say, and this is a quote, "I know you did all you could." Right? That's what they're telling you when you tell them about a mistake and you're apologizing. They actually will sometimes grieve with you because they see the elements of an appropriate apology. They actually see that you're experiencing shame. You're conveying to them your feeling of remorse. You should be telling them what you're going to do differently in the future so that other people won't have that event. You've made yourself vulnerable. You heard that, right? And you've also given them information about what happened. By the way, patients also have guilt. It's a funny symmetry. You feel guilty if you did something that caused the harm. Sometimes patients feel it's something they didn't do. They didn't call you soon enough. I mean, there are any number of reasons they feel guilty. So when you lay out the facts, you can also be assuaging their guilt. So it's actually very symmetrical. So at the end of the day, I'll just remind you that apologies do a great deal for patients. You heard that. They also can do a lot for you. But they're very difficult because of the fear that Heather reminded us of. So what I hope you'll take away with your handout and the CD is data that the fear part is not as great as we imagine. It's not zero, but it's not as great as we imagine. And the benefits are substantial to both parties, and your handouts will give you the how to do it, how to disclose, and how to apologize. Thank you so very much for your attention. See?
Get the handout over on this side of the room.
Okay. Handout, but the CD has the same information, so you'll get it.